Thanks so much.
You can go on to the next slide, please, Kathy.
So tonight we're going to talk about perimenopause and menopause. And like Dr. Kim said, Menopause 101. First, before we do anything, we have to define perimenopause and menopause. So menopause is a normal natural event defined by the final menstrual period and confirmed after 1 year of no menstrual bleeding. It typically occurs between age 40 and 58, and the average age of menopause is 51. The time prior to menopause is called perimenopause, and that the length of time can vary. Women worldwide are living longer, and many women will spend nearly 40% of their lives in postmenopause. More than 60% survive until at least age 80 years old. Next slide.
So we wanted to talk a little bit about some of the stages of aging. We wanted to present a couple of little fun facts for you. So chronologic aging means that natural process that happens over time, and it's influenced by lots of things in your genes, your environment, factors like diet, stress, your lifestyle. An interesting fact is that when you are about 20 weeks gestation, you have the most number of eggs that you'll ever have, about 6 to 7 million. And then over time, we lose them. And by time of menopause, you only have about 300 to 400 eggs, most of which are really not able to be fertilized. So this is a normal process that happens over time.
Next slide. So since this is a talk about perimenopause and menopause, we need to get to the most common symptoms that we see in our practice, and there are many. We see sleep disturbances, we see changes in weight, changes in body habitus, we see genitourinary syndrome of menopause, which we're going to discuss more at length later. We have patients come in with lots of health concerns in perimenopause and menopause, osteoporosis, cardiovascular disease, and cancer. The symptoms of perimenopause and menopause, which again, we're going to discuss more at length, often start prior to menopause in perimenopause. The multitude of symptoms that we're going to discuss vary in patient to patient. They vary as far as the quality and the quantity and how disturbing they are, how they affect the quality of life. So as we like to say, there's no one menopausal syndrome. Everyone experiences it differently. Next slide.
Next slide, Kathy. So we talk about abnormal bleeding. If you recall, the talk is titled Blood, Sweat, and Tears. So menstrual bleeding that is considered abnormal is any kind of bleeding that is considered too heavy, too often, and or lasts too long. And we see that very often in our office for abnormal bleeding of any kind, particularly in perimenopause. It's a very common complaint. And what's really important for you to realize is at any time, once you are menopausal and you've stopped bleeding for over at least a year, and you do have any kind of bleeding, whether it's spotting or heavy bleeding, it must be thoroughly evaluated. You must see your physician and make sure that you have a thorough examination and testing to make sure that everything is okay. Next slide, please.
So the talk is named Blood, Sweat, and Tears. The next part of it is sweat, the most common symptom of menopause. Vasomotor symptoms, we call it, or VMS. So VMS, hot flashes, night sweats, day or night. They can be accompanied by sweating, chills, anxiety, heart palpitations. They're characterized by sudden intense changes of heat in the upper body, particularly the face, the neck, the chest, and last approximately 30 seconds to 5 minutes. Again, the number of episodes and degree of how disturbing it is varies from person to person.
Next slide. Next slide, Kathy, thanks. So, VMS, or the vasomotor symptoms that we talked about, affects up to 80% of women during perimenopause. And if you're on this talk, I'm sure all of you know exactly what we're talking about. But it's important to realize that it does happen at all different times. So in premenopause, we know that up to about 21% of women will report having these symptoms. In peri, again, the time period before you stop getting your menstrual cycle, 40% will also report having experienced these symptoms. And certainly in postmenopause, at least 42% of women will report having these symptoms. So the point is that it can happen at all different phases of a woman's life. Next slide, please.
So looking at some data, there was a study called the SWAN study, which stands for the Study of Women's Health Across the Nation. It started in 1994 as a longitudinal study, meaning over time, and examines the physical, biological, psychological, and social changes across the menopause transition. And it looks at different ethnic groups. So another fun, but yet not so fun fact is that African American women have the longest duration of symptoms across the menopausal transition. The earlier onset of menopause, depression, anxiety, stress, smoking, and obesity are associated with longer duration of symptoms. And sadly, approximately 10% of patients or women experience vasomotor symptoms for more than 20 years.
Next slide. Next slide, Kathy. Thank you. So this slide is talking about the tiers, which lots of us can relate to. And we like to use this little acronym for the tiers of other common, very common symptoms that women experience. Tiers for temperature changes, the hot flashes, the night sweats. E stands for emotional changes, mood swings, irritability, anxiety. A can be for aches and pains, joint pain, muscle sickness. R can stand for restless sleep and restlessness, insomnia, frequently waking up. And S for skin changes, sexual changes or problems, including dryness, pain, pain with sex, and changes in libido.
Next slide. And so we've mentioned a bunch of symptoms, but there are more. There can be headaches, migraines, brain fog, memory changes, muscle, joint pains. The list kind of goes on and on. Next slide.
So we did want to spend a little time talking about what we call GSM, or genitourinary syndrome of menopause. What happens with the decrease in estrogen affects all of the area of the vagina, the vulva, the bladder, and the urethra. So a lot of times these are symptoms that people will have that are not from a yeast infection. It's not from urinary tract infection. There are dryness complaints. People will feel itchy, just irritated, uncomfortable. Certainly, it's commonly associated with having painful intercourse or lots of urinary symptoms, urgency, going to the bathroom frequently, or nocturia, which means that you get up at night a bunch of times to go to the bathroom. Or unfortunately, some women will have recurrent urinary tract infections. All these symptoms are really can impact someone's sexual function, their daily life, and can be very distressing to women.
Next slide. So just as our symptoms aren't one size fits all, there are many options for treatment, especially of vasomotor symptoms. We have non-prescription and we have prescription medications. We have hormonal and we have non-hormonal options. Our options are constantly changing, and thankfully more and more research is finally being done on women's health and menopause. And we're hopefully developing more and more treatment options. For example, about a week ago, a new medication came out with FDA approval for non-hormonal symptom treatment of vasomotor symptoms, and there's more to come. Next slide.
So just spend a little time. There are some non-hormonal options, and these have been well studied. So they look at studies to see whether or not there is an improvement and a reduction in women experiencing vasomotor symptoms. Weight loss has been shown to significantly improve symptoms. Unfortunately, supplements of all different kinds have not been consistently shown in studies to have an impact, but there are many mind-body therapies. For example, hypnosis or something called CBT, cognitive behavioral therapy, has been shown. And there's exciting new studies and information about acupuncture. And there are some ongoing trials looking at the benefit of acupuncture in diminishing symptoms of vasomotor symptoms for women. Next slide, please.
And now, this wouldn't be a talk of menopause without discussing menopausal hormone therapy. There are multiple indications for using hormone therapy in menopause. Menopausal symptom relief would be one, prevention of osteoporosis, vaginal urinary symptom relief, and premature menopause, either surgical or naturally occurring. Next slide.
So we have this slide up. This is actually a slide from my resident lecture. And as you can see, there are lots and lots of different combinations and medications that are available. We are very passionate here about making sure that the next generation and future generations of physicians are very well trained and educated about perimenopause and menopause options. So we left this slide up to show you that it's very important to be familiar with all of these different options so that you can make sure that you make the best recommendation for each individual patient. Next slide, please.
Because also there are side effects that can happen, especially if the correct dosages or treatments are not individualized. These are, some of the examples of things that can potentially happen. We try to obviously, limit the amount of side effects when we choose our treatments.
Next slide, please. So just want to mention also that there are specific treatments that are also including treatments for GSM. You can have local treatments that are applied, creams, some suppositories or pills. There are vaginal inserts, and there's even a ring that's used. And as a reminder, some women will use systemic hormone therapy, meaning that they'll take hormones that will affect their entire body, and in addition will give relief for some of those symptoms. But of course, you want to be able to have options for those women who may decide that that's not something that they want to do. They want to take local therapy and not systemic therapy. Next slide.
And of course, there are some more non-prescription options. There are lubricants, there are moisturizers, there's pelvic floor physical therapy, there are vaginal dilators, and there are vibrators. And all of these things can be individualized for treatment for GSM, either by themselves or with other treatments.
So it's important to understand when you have your menopause visit. So Dr. Beloff and I, when we see patients in consultation, we want to know, what are your symptoms? What's bothering you? What's the most bothersome symptoms, and how is that affecting your life? It's important to take into account the entire history, what medications you're on, what's changed, a little bit about your menstrual history. When did you go through menopause? What were the circumstances? Was it natural? Was it due to surgery, etc.? It's important to make sure that you're up to date with your routine annual gynecologic exam, having had normal pap smear, mammography, a DEXA, which is a bone density, which is a screening test for osteoporosis, and all of the lab work, including a full lipid panel, hemoglobin A1C, which is a pre-diabetes screen, thyroid test. So we want to make sure that the patient has an entire full evaluation before we start talking about what's the best option for that person. Next slide, please.
And here are some of the things we discuss at your visit or, in relation to your menopause. Like we were introduced, we are Menopause Society certified physicians, and we do recommend finding, physicians or practitioners with the most knowledge from the Menopause Society. We personalize your options, we discuss your goals, we discuss your risks, and we monitor your therapy. One size, like we said, does not fit all. And sometimes it changes. Sometimes we start with one thing and then we pivot and we have to try something else because either side effects or you don't feel well or, we want to do better. So those are the recommendations that we have when we see you in the office. Next.
And so this is very exciting. I just added this slide in actually yesterday. I'm sure all of you saw on the news flash. So the FDA just lifted the black box warning on estrogen products, which is really historic. And just briefly, a black box warning, if you've ever, and many of you I'm sure have, took out the paper with the tiny, tiny, tiny little writing about any medicine that you take, whether it's a blood pressure pill, estrogen, anything, it will tell you all about the medication. And sometimes literally there is a little black box around a warning or some concern. And so what happened is that they re-reviewed some of these warnings, the warnings that were really inaccurately reporting increased risk for breast cancer, heart disease, and dementia. And then they reviewed that information, which is almost like 25 years old data, and said, you know what, that's not really accurate. So they were able to lift that warning. And we are really excited because that's going to allow lots of women to be able to get to use estrogen if they choose to safely and feel that they shouldn't be fearful of these options. So we hope you have learned something tonight, and we're happy to share our journey. We wanted to let you know that this is the number to the Menopause Center. Along with myself and Dr. Beloff, we also have two other Menopause Society certified physicians, Dr. Tia Welsh and Dr. David Garfinkel, who are happy to see you in consultation. And as we like to say, menopause isn't the end, it's just a hot flash of a new beginning.
Now time for some Q&A.
Does staying on the pill delay onset of symptoms?
You want to take it? Yeah, go for it. So that's a really great question. And we didn't talk about it tonight, but lots of women, let's say in the perimenopausal period, say 40s, for example, will still remain on low-dose birth control pills. And birth control pills are actually a form of hormone replacement. It's a combination of estrogen and progesterone typically. So staying on them if they need contraception is actually a wonderful, easy transition way until, and we typically, for our patients, I think Dr. Beloff does it similarly, maybe you'll stay on till about 52, 53 or so. And then if they choose or are a candidate for hormone therapy, they can really transition over it. It will not, we don't have any power to delay menopause. That's not something that will be affected, but it may actually ease the transition period for a lot of women. So they don't have to go through some of the hormone changes because they're already on the pill. So some of those women kind of have a little bit of a smooth sail until they start hormone therapy if they choose to do that.
Thank you, Dr. Kim. And we have another question. Does GLP-1s have any effect on perimenopause hormones for better or worse?
That's a great question.
That's like $1 million question. A good one. I mean, we do see tons of patients on GLP-1s. They help with obviously weight loss in most patients. And like one of the slides previously showed, weight loss or, maintaining a normal body weight decreases your symptoms of menopause. So in that respect, it is helpful. There's not a lot of data about GLP-1s and hormones or any oral pills, for example, because one of the mechanisms of GLP-1s is it slows gastric emptying. It slows how your bowels and your GI system moves along. So we don't have data as far as how pills or hormones are affected. But for the most part, there's lots of patients who do both and get some symptom relief, and so in the right patients, they're good combinations.
Thank you. And another question, how long did it take for you to be well versed in menopause? Most doctors seem like they're guessing at ways to treat you.
So, I think this is something that for us, actually, listen, we're women, we're of that certain age. So it seemed like a natural part of what we were interested as well. So we did our own education, self-education. And then there is something called the Menopause Society, which is growing by leaps and bounds, like 500%. We just returned from the national meeting in Orlando, and you spend time doing additional training and testing and staying. So I would say the last few years, we've spent a tremendous part of our professional life becoming, hopefully, menopause experts. And we both can attest how gratifying it is for both personally as well as professionally, because we can relate to you. We understand exactly what's going on.
Thank you,
And we're
Dr.
excited
Kim.
that there's so many advances and people are finally trying to talk about it and trying to help women, probably more so than ever before. We are 51% of the population. So, we deserve to have those studies and that education, and, we're passionate about doing it.
Thank you. A few more questions. If you have vagina dryness, that is very painful, and I've tried suppositories and they do not seem to help. Is estrogen a better choice?
It's so individualized. So that is one of the options, but it's definitely something that I would talk to with the physician, do an exam, make sure that there's no underlying problems otherwise. And then, yes, probably that would be a solution as long as, it's appropriate in the patient.
And just, so, again, with the lifting of the black box warning. And we also, even before that happened, just so you guys know, we were still prescribing vaginal estrogen, certainly to many, many patients without hesitation, without any concern that there was risk. So this just solidifies it. But there's lots of studies. Again, we like to have lots of big studies with many, many patients studied to make sure that there's good safety data. And we feel very confident that has been for many, many years. We felt very comfortable with that.
Thank you, Dr. Kim. And if a woman comes to you, would you then become their regular GYN to see yearly for all screenings?
Great question also. So the way we work with the Menopause Center is really for consultation for menopause, because, we said there's 4 menopause certified physicians and hopefully more in the future. That's our primary focus of consultation. We have plenty of GYNs within Valley Medical Group and within Valley Hospital and the local areas. So most of the time we're going to focus on your menopause, and we're going to defer the GYN routine to either your previous gynecologist, or we have plenty of physicians that we work with really regularly.
Thank you, Dr. Beloff. Another question. I had a hysterectomy and one ovary removed in April. I'm 43. Is it important to know when I start menopause? I had hormones checked over the summer and I was only in perimenopause at the time. I'm wondering if women only need to speak with a doctor if symptoms are bothersome.
So that's actually a very good question. So it's a little bit of a nuanced answer. Yes, it is helpful in those circumstances, in your circumstance, because you had a hysterectomy, to have blood work done. And yes, many patients will seek treatment because of symptoms, but the more emerging data is coming out that there may be some other more proactive benefits, in other words, preventative health. So I just saw recently many patients who weren't really very symptomatic, but they just wanted information. They want to know, what do I expect? What are the risk benefits, like, so that they're prepared. And I think that education and that preparation, just so that you know that you don't have to wait till you're symptomatic, is very valuable. But yes, I think it's good to get information early on.
Thank you, Dr. Kim and Dr. Beloff. I have some more questions. How do I know my symptoms are related to menopause and not just stress? General anxiety, family history. When do I know to call to see if it is a menopause related?
So that's a tricky question because, as we know, fluctuations in hormones and decreased estrogen can cause irritability, stress, depression, anxiety, and at the same time, situational anxiety, depression, stress can cause symptoms. So, the answer to the question really is we treat symptoms, and menopausal, symptoms are very closely linked. Sometimes we don't have the answers, like the chicken or the egg, but nonetheless, we can make you feel better if we do the right things. Yeah, whether it be hormones, whether it be other medications, there's lots of different options as far as treatment. But if you're not feeling well, then that's what we're here for.
Yes, and I'm just going to, remind you of that one slide about the menopause visit. So remember, it wasn't just, focused on, oh, your hot flashes. It was focused on your overall health. It's very important that we make sure that your overall health is good, right? So yes, that's certainly a piece of it, but you've got to make sure that you are taking care of all the other aspects and making sure there's no underlying thyroid problem or diabetes problem or something else contributing to it.
Thank you. I have another question. If you do not get treatment for GSM, does it get worse?
Yeah.
Yeah, it doesn't get better.
It doesn't get better. With aging comes what we call atrophy. And so over time, the tissue becomes less stretchy, less vascularized, and has more dryness. So yes, the answer is, there's no reason to suffer. There's things like you saw in the slides that we can try, hormonal, non-hormonal. There's lots of different options, but over time, it does kind of get worse.
Thank you. Should women whose families have a history of gynecological cancers avoid HRT?
Great question also. So, it really depends on that person, of course. But really nowadays, there's very little black and white. There's mostly gray. And I think that we do something, Dr. Beloff and I, something called shared decision making. We talk about, with the available information, let's say someone has a family history of breast cancer or a family history of uterine cancer. We talk about, well, what are the risks? What testing is available? What can you do proactively to minimize your risk? And then with that said, you still need to live good quality of life. You can't just suffer and be fearful of that as the only driver. So again, each individual woman is different, but you should have the conversation. You shouldn't automatically assume, well, I have a family history of cancer, so, it's definitely not an option. Maybe it's not an option for you to do systemic therapy, but maybe you could do local therapy. So you shouldn't, it's not a black and white. Everything is gray.
And we're getting more and more information as time goes on. We're changing. I always say what I talk about today is different than what I talked about 2 years and 5 years ago. And it's different than what I will be talking about, hopefully 2 years and 5 years from now. So it's an ongoing conversation.
Thank you. So who would not be a candidate for HRT?
It's pretty small, but someone who, let's say, is actively having bleeding and hasn't been fully evaluated. Someone who currently is in the midst of cancer treatment is probably not someone who is a candidate. Those are like the two things that come to mind that are like the definite, probably no's.
There's some cardiovascular, issues that we want to, work with. We, in our menopause center, we have a team of not just gynecologists, but we work collaboratively with oncologists, with cardiologists, with metabolic disease, endocrinology, nutrition. So, if somebody is maybe not a great candidate, but it's an appropriate, patient that we might want to, fine tune, we'll send them to our colleagues in the cardiology center, or, we'll try to work on lifestyle modification, things like that, that we can do if they're not currently a good candidate for hormones.
Yes, that's a very good point. So again, things do change. I am thinking of a particular patient that I have actually who completely changed her life around. She stopped smoking, she exercises, she's a completely different person. And her previous person, I probably wouldn't have felt comfortable. She was a smoker, she wasn't in a great cardiac shape, but she made some changes and now she's doing really well. So yes, I think that's a very important point. And it's really important to know that we're very fortunate that we have these really great other physicians that we can talk to as a team and say, hey, what should we do with this patient? How should we take care of her? So we are very fortunate that we have that here.
And again, that's where shared decision making is really important. We treat the patient. We listen to what the patient, says. Sometimes there's risks that outweigh the benefits from a on paper medical standpoint. And we have to go through those and say, okay, is this really something that you want to do? Then you get to make the decision, as long as you understand that can sometimes be some pretty serious risk. That's part of the nuance and the specialty of menopausal medicine, and all medicine in general, but specifically what we do.
Yeah. Would you be able to talk about the different estrogens that we can take? For example, bioavailable, synthetic, etc. What does all of that mean?
Oh boy. We don't have that kind of time, but we'll try to summarize it a little bit. You want to tackle that?
So bioidentical is a term that really implies it's what your body had before. And estradiol, which is a pharmaceutical medication, is bioidentical. It's what your body had before. Premarin was, got a lot of attention back with that big WHI study, and that was natural and made from, horse urine. So we've evolved. A lot of people use the term bioidentical to mean not pharmaceutical and more compounded. And that's why we laugh. We have a whole, conversation about, the risks and benefits. So what we use and what we favor is based on, our data and our evidence and the recommendations for the Menopause Society. And those things are the pharmaceutical, bioidentical, estradiol, micronized progesterone. Those are bioidentical medications. If that answers the question. Did I do a good job answering the question?
Yeah. Sort of. And it is confusing because there's a lot out there in social media, etc. And some of it is not necessarily different. And so what I would just caution you, whatever choices you make sure that you're really getting what you pay for. In other words, there's a lot of things that are readily available that are very affordable, that are covered by your insurance. You don't necessarily need to go to some place that makes something specific or special that is that you have to pay for, that's very expensive. And that's what we're want you to understand, that that's not necessarily safer, better, or more natural. So those are just little distinctions.
Thank you. And after your body goes through menopause, Do many of the symptoms stop, and how long do symptoms typically last for?
Yeah.
I think that, well, it depends on which symptoms. I think that goes back to the slide we had earlier in the night that, symptoms can last a short time or a long time. It really varies. It really is an individual thing. And it also, I think you remember that SWAN study, there are ethnic differences as far as how long your symptoms last. There are genetic, favorabilities as far as if your mother went through menopause and had a, early menopause, you're more likely to have an early menopause. If, the symptoms were over a really long period of time, that's more likely to be something in your family that, if your sisters and your mother and your aunts all had, 20 years of menopause, it's more likely, or symptoms, it's more likely for that to be the case as well.
Thank you. And can estradiol cause vaginal cancer?
No,
Mm-mm.
no, there's no association between estradiol and vaginal cancer. Estradiol is the natural form of estrogen that you had, that your ovaries make most of your life until you go through menopause. So that's not a concern.
Mm-hmm.
Thank you. And does menopause increase my risk for osteoporosis or heart disease?
So yes, estrogen deficiency is linked to osteoporosis and heart disease. So if you remember the slide, one of the reasons for treatment with menopausal hormone therapy is prevention of osteoporosis. If you're, a young patient and you have a bone density and you have osteopenia, and again, your mother, your aunt, your sisters all had, osteoporosis or frailty, that's one of the reasons that we use menopausal hormone therapy to prevent osteoporosis.
Excellent. Thank you. Oh, here we go, another one. If you start HRT, are you on it for life? And how do you know when to phase off?
So that's a really good question also. These are great questions.
These are really good questions.
And it's interesting because if, again, like Dr. Beloff said, if we talked about that a year ago or 2 years ago, the answer would probably be a little bit different. So initially we thought, well, you treat until people feel a little better for a few years and then, you're fine. So remember, there's symptomatic treatment. But then now also we feel that, again, if you have no increased risk, nothing changes since the time you started, and there may be some ongoing health prevention and benefits, we sort of leave it open-ended right now, that we don't have an end date. Certainly someone might, God forbid, something changes, they decide, or they, have a medical contraindication. They get, let's say, a blood clot, for example, then, they really can't take estrogen any longer. Certainly that might change. But if you're doing well and there's nothing else that's dramatically changed, right now it is open-ended. And there's no reason to say, okay, it's 5 years, boom, you got to stop taking it.
Yeah, the data will catch up to us.
Yes.
Oh, I think you guys did a wonderful job.
Oh, thanks.
Same.
Thank you.
Yeah, yes.
Thanks.
We can't see.
We don't see, but thanks for showing up, and
Hope you learned something.
hope this was helpful.